Good afternoon. Welcome to Journal Club. I'm Laura Tolan. I'm Senior Editor with Health Affairs, and I am pleased to introduce today's featured paper, Housing-Sensitive Health Conditions Can Predict Poor Quality Housing, written by lead author Daniel Neal of NYU and a team from NYU's Wagner School of Public Service. Today we'll be chatting with Dr. Neal, whom I will introduce properly in a moment, but first a few announcements I wanted to get to. Journal Club events like this are typically exclusive to Health Affairs Insider members, which is a community offering exclusive access to content beyond the Health Affairs subscription. Today's event is open more broadly thanks to our funders of the February special theme issue on housing and health, of which Dr. Neal's paper is a part. So we're glad to have you all here with us today, whether you are an insider or not. And if you are not and you would like to be, we encourage you to join. You can use the special code HAInsider10. That's HAInsider10 for $10 off an insider or an unlimited membership at healthaffairs.org/subscribe. A few housekeeping points about how today's session is going to run. The chat is disabled, the Q&A is working. We ask that you enter your questions into the Q&A tab in the toolbar at the bottom of the screen. You don't need to wait until the Q&A portion to put those questions in. You can write them at any time, and I encourage you to please do that and keep them coming. We're really hoping for a lot of good audience participation. We've got a nice size audience today. The event also is being recorded and will be accessible on the Health Affairs website at healthaffairs.org. So with that, I am now going to introduce Dr. Neal. Daniel Neal is Associate Professor of Computer Science, Public Service, and Urban Analytics at NYU, among many other affiliations at NYU. He also directs the Machine Learning for Good laboratory and recently finished a 3-year term as co-director of the university's Urban Initiative. His research focuses on developing novel machine learning methods for social good, as you'll be hearing about today. And these have applications ranging from medicine and public health to urban analytics and fairness and criminal justice. So I'm going to turn it over to Daniel, who will take 25 to 30 minutes or so and talk about the paper. And again, I just want to remind everyone that you can drop your questions into the Q&A at any time, and we will get to those after Dr. Neal completes his presentation. So take it away.
All right. Well, thank you so much, Laura, for that wonderful introduction. Thank you for the invitation. Thank you, everyone, for being here. So this was kind of a really fun and very interdisciplinary paper. So as a little bit of background, I'm a faculty member at NYU, jointly appointed in the Computer Science Department in the Center for Urban Science and Progress and in our Wagner School of Public Service. So my own background is pretty interdisciplinary, but I also had the benefit of working with a really amazing interdisciplinary team. I'll mention specifically Agni Chakraborty, who is a master's student who did a lot of the analyses under my supervision, as well as really benefiting tremendously both from the housing policy expertise of Ingrid Ellen and the health policy expertise of Sherry Gleed, but really just a great team of co-authors. So, really delighted. So this, as I said, this work really thinking about the intersection of housing and health. We are really just so fortunate to have been supported by the Robert Wood Johnson Foundation, as well as to receive New York State Medicaid data from the New York Department of Health. So all the usual disclaimers apply, and we're very grateful to both Robert Wood Johnson and New York State. So this study really focused on trying to answer two main research questions. The first question is, which health conditions are most strongly associated with poor housing? Right? There's a general consensus that poor housing may lead to poor health, but I don't think we really yet understand the specifics. So, which poor housing conditions impact which health conditions for which subpopulations and for whom? So this is sort of building on some of that literature and really trying to do a data-driven analysis of understanding at building level the associations between poor housing and very specific health conditions. The second research question is how do you put all that together? So in other words, once we've identified specific health conditions, how can we actually build a model using all of those health conditions to inform us, to predict which buildings might actually have poor quality housing. And then the idea is that that sort of health data, specifically Medicaid health data, can actually be used to target the city's building inspections. And of course, not just toward any poor quality housing, but specifically targeting that toward poor quality housing that may most impact health. So to address the first research question, this is kind of the big reveal here. We identified 23 different health conditions that were strongly associated with poor housing. These we term the housing sensitive health conditions, or HSHCs. We'll talk a little bit about how we got those very soon. Our second main point is we built this predictive model called the Housing Health Index, which will predict whether or not a building is on the New York City landlord watch list. And we did that using those 23 health conditions as predictor variables. So a little bit more about the landlord watch list also in a minute. So just to kind of situate this a little better, we've already seen a pretty nice and growing literature suggesting that the quality of housing is associated with many different dimensions of health. So different studies have, really drawn some of these causal connections, and in particular, identifying kind of specific housing improvements that, when made, actually will impact specific health conditions. So for example, connections between pest management and mold remediation and improving asthma rates, remediating lead paint, which leads to reductions in blood levels, structural improvements leading to reduced injuries, and then heating system upgrades that might actually improve residents' mental health, as well as potentially hypertension as a sequel of some of those anxiety related disorders. So another really important piece of related work is some recent work by Liz Samuels and co-authors, basically doing kind of something similar to what we're doing, but maybe a little more specific, in that they were able to show that specifically looking at asthma, elevated rates of asthma were predictive of failed housing inspections. So we build on this literature in a couple of ways. As I said, first, we have a data-driven analysis, and that data-driven analysis is taking many different possible health conditions that might be associated with housing quality and actually seeing in the New York City Medicaid data which ones actually are, and looking at that both separately for both children and adults. Additionally, we are using multiple health conditions, and we're using them, as I said, in tandem to build a richer model for predicting poor quality housing. So the idea is, by understanding all of the different health conditions, we should be able to do a bit better. So another bit of related work that I want to mention is work by my colleague John Billings on ambulatory care sensitive conditions. So this was a really phenomenal work that basically said, if you can identify specific health conditions that are increased in certain areas, they might actually be used to identify that those areas have inadequate access to primary care. So this was actually kind of a big part of our thinking, that we could actually identify a similar set of housing sensitive health conditions that identify the areas, and in this case, the buildings, with inadequate housing quality. So a little bit about the different sorts of data we used. First set, again, that we really could not have done the study without, was health data from New York State Medicaid. And we aggregated that data at building level to basically calculate the number of Medicaid recipients, adults and children, in each New York City rental building, with at least 5 units for each study year. And then out of those numbers of adults and children, how many had each of 65 different health conditions. So second data set, data from the New York City Landlord Watch List. This is a list created each year by New York City's Office of the Public Advocate, and is basically the buildings that in their mind are kind of representing the worst buildings and worst landlords throughout the entire city each year. So housing violations are a big part of what goes into this, but there are a lot of other criteria as well. And the way I would think about this is really kind of, it doesn't necessarily represent every building with poor housing in New York City, not by a long shot, but you can think about this as kind of a subsample of the very worst in the city. We also had several sources of additional building level data. So for each building, we had its borough, community district, number of residential units, and subsidization status. We additionally had some building level data that we use just for evaluation. So this is really to see if our housing conditions correlated not only with a building's presence in the landlord watch list, but actually with poor housing based on a number of other measures as well. So in other words, we thought about things like the number of housing violations, the number of resident complaints to 311 for different agencies like NYC's Office of Housing Preservation and Development, Department of Housing Preservation and Development, Department of Buildings, and Department of Health and Mental Hygiene, as well as a number of emergency repairs. So our approach really took two steps. First, identifying those housing sensitive health conditions, and then using them to build this predictive model, the Housing Health Index. So to identify housing sensitive health conditions, we used a binomial logistic regression approach, which basically means that we took each of the 130 health variables. So that's basically the 65 different health conditions, done separate analyses for adults and for children. For each of those variables, we tested whether a building's presence on the landlord watch list was associated with increased prevalence of that health condition for the subpopulation of Medicaid recipients, again, for Medicaid receiving adults or Medicaid receiving children. So think about basically 130 different, essentially univariate analyses, but we did control for various things. So we actually used 8 different binomial logistic regression specifications. Each specification had a different subset of control variables, including subsidization status, borough, the number of adults and children on Medicaid, and number of residential units. So what we did then, after we ran those analyses, was we basically took the union of the health conditions found to be significant. So more precisely, we looked at those binomial logistic regression coefficients and found the ones for which the coefficient of that binary variable, whether or not that building was on the landlord watch list, was both positive and at least weakly significant and at least one of the 8 specifications. So that is what we chose as our housing sensitive health conditions. So again, you notice we're kind of erring on the side of including things that are at least weakly significant because, again, the overall goal is to build a predictive model. And so we wanted to make sure that everything that actually was important is going to be in there. So this is the list that we ended up with of the housing sensitive health conditions. And again, running these 130 different analyses, we ended up with 23 different variables that were actually at least weakly significant in at least one of the analysis. Now, it turns out that actually a lot of these variables were very strongly significant in all of our analyses. I think what was probably even more exciting, though, was the fact that these, even though we considered a wide variety of different health conditions, the ones that actually came up as significant really clustered nicely into these 5 specific categories. So respiratory illness, specifically asthma, for both adults and children. Cardiovascular illness, including stroke for adults, was the most significant of those. Substance use, primarily for adults. Injuries for both adults and children. And then really a wide variety of mental health conditions, the most significant of which were for children. So this includes things like attention deficit and hyperactivity disorder, adjustment disorders, mood disorders, really kind of a lot of things relating to depression, anxiety, and kind of things that might result from being in those sorts of circumstances. So again, we came up with, kind of a very kind of nicely clustered set of conditions and ones that made really a lot of sense when you think about what housing could potentially be impacting. So this brings me to the second piece of the methodology, which is the creation of the Housing Health Index. So again, this is basically a predictive model using the health information. So using the aggregate count of each of those 23 housing sensitive health conditions, as well as 5 additional control variables: borough subsidization status, number of residential units, and number of Medicaid enrolled adults and children. The target variable for this analysis was, again, each building's probability of being included on New York City's landlord watch list in a given year. Again, think about that as a proxy for the building having extremely poor housing conditions. So we used in our primary analysis a statistical machine learning approach called random forests to make that prediction. So the resulting model was learned from training data, and then when we predict, we call that predicted probability its housing health index. Right? So each building has a housing health index, and we're particularly interested in the buildings kind of in the very top, in this case decile, but kind of the top range of housing health indices. So we used a cross-validation approach, more precisely stratified cross-validation, both for evaluation, which think about basically splitting your training data from held out data to measure performance, and also for model selection. That's basically splitting up the training data to better learn our model. So really, stratified cross-validation means 2 things. Again, really important thing to keep in mind is that performance is measured on held out test data. So that's data not used to train the model. The other bit is, again, the stratification, which is we only compared buildings, again, both in our model selection and evaluation step, to other buildings that were similarly sized in the same borough and had the same subsidization status. The reason for that is that we're not just interested in learning something like bigger buildings tend to show up on the landlord watch list, or buildings in a particular borough tend to occur on the landlord watch list more often. We wanted to control for those factors like borough subsidization status and size, and again, based on that, understand the impact of those health conditions. So what we measured as our main performance measure was a stratified AUC. That's a stratified area under the receiver operating characteristic curve. So for those of you who are familiar with our C-curve analysis, think about basically just separating the buildings into strata based on kind of borough subsidization status and size, and computing separate AUCs for each of these strata, and then averaging over all of those different strata. So what does that mean for those of you who are not familiar with AUC analysis? Well, you could really just think about this as estimating the probability that if we have a building on the landlord watch list and a very similar building, so same borough, same subsidization status, same or similar size, that is not on the landlord watch list, what is the probability that our model predicts that the landlord watch building has a higher HHI score than the non-landlord watch building? Again, just using that health information and the control variables. So what we found, just in terms of kind of relative performance, is that the housing sensitive health conditions really were the only variables that matter. In other words, we ran the model using just the 23 housing sensitive health conditions and 5 control variables. We ran an expanded model using all 130 health variables and the 5 control variables, and those 2 models performed essentially exactly the same. In other words, those 23 variables really are capturing all the predictive information out of that full set of health variables. And of course, if we didn't perform much better than just using the 5 control variables, then we would say, hey, these housing sensitive health conditions are not particularly useful. But in this case, again, performance was much better as measured by that stratified AUC measure. And finally, we did compare random forests to a more typical statistical approach, logistic regression. And we did see better performance for the random forest model as compared to the logistic regression model. In terms of absolute performance, well, the stratified AUC, we did see variation from year to year. And one thing this seemed to depend on was the size and other characteristics of landlord watch list buildings. So for example, for the year 2017, it seems like the landlord watch list buildings were smaller. They tend to have fewer Medicaid enrolled residents, fewer residential units. And as a result, I think, our predictive power was lower for that year. The other thing to remember is that we're not really trying to predict, presence on the landlord watch list. Like, that's not our end goal. What we really care about is overall poor conditions, poor housing conditions. And there are a lot of buildings out there that have poor housing conditions that don't end up on the landlord watch list, which is going to take me to my next analysis. So actually looking at some of these other conditions, like housing violations, 311 calls for service, etc. The other thing I'd mention is that it appears based on our analysis that most of the useful information is in the top decile of housing health index scores. So in other words, it doesn't really matter if you're, in the 6th decile of housing health index versus the 4th decile of housing health index. All of those really have relatively low probabilities of ending up on the watch list. Housing health index doesn't distinguish those very well. But what it does distinguish is these buildings with very high housing health index scores do actually not only appear on the watch list a lot more often, but have a lot of other indicators that you would associate with, yes, these buildings really do have poor housing. So that brings me to kind of the main evaluation. Again, how well can we identify poor quality housing using the prevalence of housing sensitive health conditions? And our main result is the following. If you compare it with a similarly sized building in the same neighborhood with the same subsidization status, a building in New York City with high rates of housing sensitive health conditions, so in other words, that's a building that's scored in the top decile as measured by our predictive model, our housing health index, is about twice as likely to be on the landlord watch list. But more than that, it has a lot of other indicators as well. So many more calls to 311 on average. That's 71% more 311 calls to New York City's Department of Housing Preservation and Development, 50% more to the Department of Buildings, and 38% more to the Department of Health and Mental Hygiene. It had a lot more emergency repairs, 65% on average, and also had both more, about 50% more total housing violations, as well as over 50% more immediately hazardous Class C housing violations. So the bottom line here is that a building that has a lot of housing sensitive health conditions, again, as measured by our HHI, really has a lot of different indicators that this building does actually suffer from poor housing conditions as well. So let me talk a little bit about the limitations of the work, and then I'll jump into kind of some of the practical uses of it. So one very important thing to keep in mind is that this is an association study. What we're really trying to do is predict whether or not a building has poor housing, given what we observe of the health conditions of the Medicaid recipients. So again, this is a predictive rather than causal analysis. Again, what we're not doing is to identify causal effects of poor housing on health. That is actually something we are planning on doing more of as a follow-up. Second limitation is, of course, that the analysis is limited, and it's limited in several ways. It's limited, to the Medicaid population. Those are the people who we actually had health data from, as well as being geographically limited to New York City. So again, I'd be very careful before we, generalize outside of that particular analysis. Two aspects of the Medicaid population that are worth knowing, noting. One is that it's, of course, a lower income population. And the other is that it's typically people under age 65, because at age 65, most people are moving from Medicaid to Medicare, and we did not have data for Medicare. So again, think about this really as kind of building conditions that are associated with poor health among children and, non-elderly, or at least under age 65 adults. I mentioned that landlord watch list is really a sample from the set of buildings with poor housing conditions. It's really unlikely that a building with good housing is going to actually end up on the landlord watch list. But there is a big question about, out of the really bad buildings, how do they get selected? So I would argue that there are various confounders that may impact whether or not a building with poor housing conditions and a lot of housing violations is or is not actually placed on the watch list. One of the things you look at with the landlord watch list documentation is that there are some, basically recourse for the landlord to say, oh, I am, in the process of improving and, please take me off the list. And so again, I do think that there are, potentially some political considerations there, hard to say, as well as, just in terms of, measuring things like housing violations, a lot of which is reactive based on 311 calls. Well, it depends on who actually reports those problems to 311. So again, it's an imperfect measure, but I do think it's actually really nice as an aggregate measure of kind of, the very worst buildings in terms of housing conditions. Finally, one note is that we do have sample size limitations. So what this means is that if a particular building just doesn't have any Medicaid enrolled residents, we're not going to be able to say much of anything about that building. So in other words, our housing health index, because it's based on the rates of housing sensitive health conditions within each building, it can only identify a building like, hey, this is one you need to look at if that building actually has enough Medicaid enrolled residents to have any sort of statistical power to say, yes, the rates of housing sensitive health conditions are in fact increased among that population. So despite these limitations, I would argue that this work does have a lot of useful implications in practice. So the way I look at it is that cities can really do three different sorts of things with these results. So the first is it's very important to keep in mind that the majority of housing inspections are reactive. So these housing inspections are typically based on 311 calls for service, based on the reported problems. And so even there, I think we have potentially a lot of use because, the city has limited resources. It does take a while to get to some of the housing inspections. And so I would argue that high housing health index buildings should be prioritized for housing inspections because these are the buildings that are most likely to have housing issues that are actually impacting the health of the building's residents. Second, I'd argue that when a housing inspector actually goes to inspect one of these buildings, they should be informed of the specific risks to residents' health that are in that building. So in other words, if a building has high housing health index and let's say high rates of asthma, then building inspectors should actually know that coming in and being able to look at things like risks to air quality specifically for their inspection. Finally, I would argue that that inspections don't just have to be reactive, but that cities could actually discover unreported housing issues through more proactive inspections. So in other words, when a building is really really bad off in terms of the health of its residents, specifically for those conditions that are very strongly associated with bad housing, perhaps that is actually justification for the city to not wait until someone makes a 311 call, but actually investigate proactively and see if there are specific housing issues there that may impact the residents' health. Finally, I'd argue that, this is not really just to drive housing inspections. And one reason for that is because there are some risks from housing inspections. So for example, if, for example, a building gets closed down, then of course, that could actually negatively impact the residents of the building. So I would argue that it's very important for cities to actually combine these code inspections with other things, including tenant protections and provision of social services. Additionally, this sort of information can be used not just by the city, but by community-based advocacy groups who can actually, really, identify these sorts of patterns and speak up for the residents who are affected by these sorts of poor housing issues. So with that, I think we're at 3:30, so I am happy to open it up for questions. And yeah, thank you everyone for listening.
Right, thank you, Daniel. And I guess you can drop the slide if something comes up. Maybe we can, if somebody has a question, we can go back to them. But we have had a couple questions that have come in through the Q&A. I'm going to encourage people to keep those coming. There were two questions that came essentially asking for Nope, I just lost them. Asking for a little bit more detail about the population that you studied. It's in two different ways. One is around the age distribution. So the question was asked, you did look at Medicaid, but people can also be on Medicare with Medicaid. Did you look at the over 65s and kind of, can you say a little bit about how the ages were distributed and what might be some limitations related to that? And the second question is about the geographic distribution or concentration of your folks, whether any of the housing units were geographically concentrated in certain areas of the city, and whether there might be something related to geography as opposed to building going on there. So let you take either or both of those.
Yeah, so thank you. Those are both great questions. So in terms of the over 65 population, we excluded that population from analysis simply because we did not have enough people who were over 65 in our data to really be able to say much. So they're just, again, they're just really is not sufficient sample size at building level to be able to say something about the over 65s. And so we really just focused on kind of the adults 18 to 65 and the children under 18. So the other question, could you just
Yeah, I can read you the question as it was written too. Was there
Yeah.
geographical concentration
Yes.
of multiple housing units housing people with health conditions? In other words, was the condition truly tied to the building or more broadly prevalent in largely geographic community?
Yeah, that's again another really good question. And the short answer is yes. There are absolutely areas of town where there are, larger proportions of Medicaid recipients. So in other words, there are definitely portions of town where, you might have buildings with nobody on Medicaid in them. In which case, again, those specific buildings, if they have poor quality housing, we're not going to be able to know about it or say much about it. That being said, we did really see, again, data from all over the city. There were, in the vast majority of neighborhoods, there are, in a lot, in a lot of the large rental buildings, sufficiently many Medicaid recipients to be able to say that if there was a condition affecting the building as a whole, we would be able to look at it. I'm sorry, we would be able to, to actually draw a signal from it. Yeah, I guess that's what I'd say there.
Okay.
Yeah,
Great,
thanks.
thank you. Another question that came in, and I'm going to tag on a little bit of extra to it too. The question is, how does the poor housing affect Medicaid costs? And I know that one of your reviewers had suggested, as reviewers often do, future research you could do building upon this. And they talked about whether you could figure out whether use of this tool, how many dailies could that save in terms of quality of life. You could ask the same question about costs. Could this be translated? Could use of this tool be translated into potential dollars saved for Medicaid? What do you see as the sort of ability to use it in that way?
Well, so first of all, I love this question, and I think that's both, a great opportunity for future work, and at the same time, I want to be very clear that it's not something we can actually, not a conclusion we can actually draw as a corollary of the present work. The reason for that is because, again, this analysis is predictive rather than causal. So what we really need to get at that particular question is actually an understanding of, what happens when we intervene, right? So it's not just enough to say, okay, yeah, we're targeting these problems, but do the problems actually get fixed? What are the other downstream implications of sending the housing inspectors there, where again, it could actually result in something like, either a building being repaired or potentially, everybody being evicted from the building. So again, I want to be very careful before I draw those sorts of causal conclusions, but I do think that, it is kind of the really important next step, right? So it's like here we can identify where the problems are. And now what we want to do is have a combination of that and an understanding of what happens when we intervene in those specific places to then actually say, okay, what would the treatment effect of intervening be? Yeah.
Great. Questions are continuing to pour in here.
Excellent.
one that just came in asked whether your study was able to ascertain whether a person had a disability, and if so, what proportion of people in your study had disabilities?
That is a great question. I believe that data is in Medicaid. We did not specifically use it, however. So I'm not actually sure what the proportion was. Yeah, it was not, other than children versus adults, we did not use demographic information in our study.
Certain disabilities would be picked up as a diagnosis, though, that you were looking at diagnoses, or were those all acute conditions?
I'm trying to think if any of those would actually would be potentially caused by chronic. Well, I mean, in fairness, I mean, something like asthma, right, is a chronic condition.
Sure.
However, exacerbations of asthma, right, actually the asthma attacks that are going to have someone come in and, need them, an emergency department visit, for example. Those are certainly, again, things that are, those acute conditions caused by housing, for example.
Right. Okay, another question that came in was whether you were able to ascertain anything from the data about owner-occupied versus not owner-occupied homes, or if that would be feasible.
I think it would be feasible. Again, it's not something we've looked at, but we did have, kind of very rich building level data from NYU's Furman Center that, we've kind of, I mean, again, I think we've only scratched the surface of, and I think that would be actually something very interesting to look at is, does the presence of the owner in the building actually matter? Does it make them more likely to fix things that are, kind of most directly impactful to the quality of health of people living in the building?
Right.
So yeah, I really like that. Yeah, thank you for the suggestion.
Another variable that could be added to the model.
Yeah.
Potentially.
Absolutely.
Let me, I want to focus on the methods a little bit here for a minute, because I think,
Sure.
I think the machine learning aspect is one of the things that really drew people to this paper. And again, the reviews they said things like clever or brilliant, the really innovative use of data. So I think this really captured a lot of people's imagination in that way. But for those of us that are not so familiar with machine learning and what some of these terms mean, you did talk about how in training the model, or you used two different approaches. One was a logistic regression, the other was the random forest. Can you talk a little bit about what?
Sure.
First question I had was, well, is logistic regression always machine learning? So maybe you can address that. So what makes it machine learning versus not? And then how can you explain what are these two different approaches, and why did you end up going with the random forest versus the logistic regression?
Sure. So logistic regression is something that you might have covered in, for example, a, kind of more typical statistics course, right? So in that sense, it's same methodology, whether it's taught in a machine learning course or in a stats course. But, I think the really important distinction between the two is that logistic regression is a linear model. So in other words, what it's predicting is basically the log odds of your outcome variable, or, sort of a transformation of the probability of your outcome variable as a linear function of all these different predictor variables. So one thing that means is that it doesn't do so well if, for example, you have a complex multi-way interaction between many predictor variables. So in my mind, the real distinction when you move from, kind of more typical statistics models to more typical machine learning models is that the machine learning models tend to be both nonlinear and non-parametric. So non-parametric doesn't actually mean that they have no parameters. It actually means that they have lots and lots of parameters that they learn. And more precisely, as the amount of data grows, the amount of parameters also grows, and therefore you can essentially learn more and more complex models as you get more and more data. So random forest is basically one type of machine learning model that, so very briefly, is an extension of a simpler machine learning model called a decision tree. You could think about a decision tree almost like building a flowchart. So imagine I ask a series of, let's say, yes or no questions. about the variables. Is this one more than this particular value? Is this one less than this particular value, et cetera? And then, you ask those questions, and then it gets you to an answer. Okay, here's my prediction. So again, the prediction of each individual tree is really not just a linear combination of the different variables, but it really is thinking about the interactions between all of them. So the random forest is like that, but it's actually building a lot of trees rather than just one, and using all of those in aggregate to make its prediction. And then there's some nice tricks in terms of randomization, using different subsets of the data, subsets of variables, such that each tree kind of captures different bits of what's important in the data. And so the combination of all of that tends to result in a very nice predictive models. So, so again, really useful approach that can build really nice predictive models off the shelf.
And so when you tested the models built these two different ways, the one built with the random forest had better predictive value, is what?
That's correct.
Just making sure I get it. Okay.
Yes.
The other thing that I thought was interesting to think about was this notion that you train the model using a certain set of, just the concept that you're training a machine to do something. You talked about this a little bit in your presentation, but can you elaborate a bit more on what it meant that you used a certain amount of the data to train the model, but you held some aside to test it, and then you also used other data to test it? If you can kind of explain that in a little more detail.
Sure. So one thing I'd mention, this is not unique to machine learning. So if I was to, again, just fit my logistic regression, right? I'm still doing the same sort of thing where it's very important to separate between the data you're using in this, so if it's logistic regression, just the data that I'm using to fit those linear regression logistic regression coefficients, right, from out of sample data, right? Because what I really want is to know how well my model is going to generalize out of sample. So the very typical way of doing that, again, is split your data, learn the model from part of it, evaluate your model on the other part. So that's part of it. Cross-validation is actually just something similar, but a little more complicated, where you do that sort of splitting between your training and test data multiple times and average over them, right? So think about removing each part of the data separately, training on the rest of the data, and then seeing how well it did on that held out part, and then averaging that over, all of the different things I held out. The other thing I'd add is that, so there's actually two different cross-validation pieces. So that's part of it, right? That you split, what you're evaluating from what you're using to learn the model. Again, what that's giving you is basically an unbiased estimate of how well your model generalizes to previously unseen data. But there's another part, which is that when you do model selection, you take the data that you were using to learn the model, again, keeping that other data held out, and you actually further split that data, right? Basically, again, learning the model for one piece of it and seeing how well it does on the other piece, and so on, in order to best fit your model parameters. So what that does is it gives you a better model, right? It gives you a model that actually will generalize better. So that was probably a long-winded answer. So I think I can stop there. Yeah.
Great, thank you. Let's shift a little bit and talk about some of the implications and the use of this tool. Well, there was another question that came in along the lines of things to study in the future. I wondered if you want to comment on it. Did you consider evaluating regional emergency department use rates in relevant catchment areas in your analysis?
No, I didn't, just because we did not have access to that data. Interestingly, I've used emergency department data a lot for other projects, and for doing things like early detection of emerging disease outbreaks. But in this case, we didn't have access to the data from the right geography and time frame for this particular project. But I do think it would be potentially useful. A lot of the emergency department data I've seen previously, at least by the time it gets to me, doesn't have exact building level addresses, right? So that's one thing that we would absolutely need in that data to be able to do this analysis of the building level.
Okay, great. So another question came in that said, what are the legislative implications? And I'll maybe build on that to say, well, are there? What are the policy implications? We can talk about the practical implications of how this tool can be used. Are there policy implications, policy enablers? You all are many of the authors are policy wonks. So, what did you all think about that?
Yeah, no, that's a really great question. So I guess maybe the distinction is whether cities would change their laws based on this analysis versus how they can enforce the current laws and regulations. So I guess I would say that I thought much more about the latter. So again, there are already housing codes, right? The goal of these housing codes, is to basically, improve the health and welfare of the recipients. That being said, I do think, there needs to be a bit of a shift in the way we think about things like inspections. Both, from just reacting to being more proactive, and also from, kind of just treating every complaint as a complaint, but versus actually thinking, okay, which of these complaints are really going to directly impact health? So again, I'm not sure that's something where new laws necessarily need to be on the books. I think it's more about city housing agencies, how they prioritize, and then again, how they can actually be more proactive in what they do. And yeah, I think some of my co-authors who are policy wonks may actually have some other ideas there as well, but I'll leave it at that one.
Okay.
Yeah.
A clarification came in too, and the question that I had asked earlier about the owner occupied. Let me just read this to you. The question was actually not because the person was thinking that homeowners would be more likely to fix health hazards, but rather it says, I live and work where housing is cheap, but incomes are low. So we have a lot of mostly senior homeowners who cannot afford to fix their homes. So a lot of ARPA and IRA funding is going to address home repairs, and hopefully it will improve health. So just I wanted to make sure I read that.
Gotcha. Thank you.
So another question, we're bouncing around a little bit here, but I want to make sure I get to these. Let's see. Did you also explore whether buildings on the landlord watch list predicted any set of health outcomes?
Let's see. Yes. So in fact, the initial analysis, which was the identification of housing sensitive health conditions, that's exactly what we did. So that was actually looking at which health outcomes, were predicted by landlord watch list presence.
I don't know if the question about outcomes was more specific to, death, or I'm not sure, but
yeah, no, well, that's a good question. One aspect of the methodology is, we started, the first analysis was using landlord watch list presence as a predictor, health as the outcome, right? But then our housing health index turns that around and says, okay, now let's take all of those identified conditions as predictors. Let's use that in aggregate to say something about the building, about the building's housing conditions. Yeah, so no, that's actually a really useful clarification. Thank you.
How about, let's take a step back for a minute. The use of these kind of data in this context is really fascinating, I think, to people. Can you talk a little bit in general about the Machine Learning for Good Lab? What else are you doing there that would be of particular interest to the health policy folk that are on the call here today?
Yeah, no, sure. I'm delighted. So as I mentioned, I direct the ML for Good Lab at NYU. It's it is a interdisciplinary collaboration of faculty from departments all over the university and students all over the university. And a lot of what we do really thinks about different ways that machine learning can actually benefit health, broadly speaking. And so that's not only what goes on in a healthcare setting, it's also public and population health, and it's more broad as well. So things like how cities can fairly allocate their services. Particularly in the public health front, two of our main application areas have been disease surveillance. So we've been thinking for really the last couple of decades about ways that cities can detect emerging outbreaks of disease earlier and more accurately, which includes some recent work on what we think of as pre-syndromic disease surveillance, which is basically how cities might actually realize. So think about, like New York City's Department of Health and Mental Hygiene, for example, how they might actually realize that something new and different is emerging, right? So not just, well, we know COVID is a problem, we're monitoring COVID over space and time, but what happens when something new and different comes along? How would they know? Right. The other thing we've done a lot of work with recently has been looking at the opioid crisis and thinking about things like predictive risk modeling, how we might be able to target interventions, both to reduce overdose overall, as well as to improve equity in who's actually getting these sorts of resources to reduce overdose. So those are some of our main projects. We really do quite a number of other things as well. We do a lot of work in criminal justice, and there really the emphasis is on how we might actually make the whole system fairer and more equitable.
Thank you. That's fascinating work.
Thank you.
I'll do another kind of more in the weeds question, and then last call for questions here. We've got a few minutes left, but one that came in was a question whether if you were able to determine if people had the health condition before moving into the building or if they acquired it during their stay there, and I would add to that, and does that matter?
So I think it does matter a little bit. So, so I mean, what one could imagine a scenario where everybody's really sick, moves into a building, and then of course we see just a big signal in that building, even though there's not necessarily anything to intervene on that's specific to that building's housing conditions. So I do think that would be relevant. That being said, as I mentioned, I do think that one of the things we see a lot is even if it's something that's maybe driven by an underlying condition, a lot of these are still acute, right? So that could be acute exacerbations of an underlying condition, which again, it's that is something that the environment and housing in particular has a big influence on.
Great. Okay, let me just take a quick skim through here. I got most of these. Let me just ask you and wrap up. This will be the last question I'll lob at you today. Sure. What did you find to be the most surprising or interesting thing to come out of this work? There's so many interesting aspects to it, but what really stood out for you?
Yeah, no, that's a great question. I think what maybe a lot of people might have found surprising is that there really is enough of a signal in who is getting sick to actually be a good predictor of which buildings have poor housing. I mean, I was to some extent expecting that going in, because otherwise we wouldn't have done the study. But I do think that's something that was not known beforehand, and so I think that's kind of a really important finding there. I think kind of what surprised me was when I was actually doing the analysis for identifying the housing sensitive health conditions, really just how nicely they fell in these specific categories. So we were looking at a lot of conditions outside those categories, and yet these were really the only ones that came up. And so again, a number of different mental health conditions, different sorts of injuries. It was interesting in the respiratory illness, we thought we might see, more, kind of like acute infections and so on. It really was just the asthma that was positively correlated with poor housing. But yeah, so the fact that they kind of laid out the way that they did, I think for me was the most surprising. But I think simply that, being able to predict poor housing, I think was kind of the, kind of maybe the most important bit there.
Great. And you know what? I know I said this was the last question, but I do want to just throw one more. We do have a minute.
Sure.
So what's next for Chicago? So if Chicago wanted to use this, would they be able to use the model you built in New York, or is this the kind of thing where each city that's going to use it needs to sort of build based on its own characteristics?
Yeah, so to some extent that's to be determined. Because one can imagine just taking the model off the shelf and saying, okay, what would happen if we just, let's say, again, this is a city where we would have to have, state Medicaid data,
Right.
but we would not necessarily have to have, like a landlord watch list, for example. So if we just use the model we learned from that, what happens, right? Do we actually see that the buildings with a high housing health index do translate into into the poor housing conditions.
Right.
And again, that's not something we've done, so it's something we would have to actually find
Next
out.
paper.
Yeah, absolutely. But kind of the other aspect of that is, if it doesn't, and it very well might not, because again, we don't know how well these results generalize city to city. What sort of a model would we learn from that new city? And it wouldn't necessarily be using landlord watch list as an outcome variable, because again, not every city has its own landlord watch list. So we may use other building level indicators. Again, things like number of housing violations, number of emergency repairs, et cetera, and maybe build a model targeting those. And then I would expect that model, one that's kind of specifically geared for, for a new city to actually do very well.
Okay, great.
Yeah.
Look forward to seeing so many interesting questions you can look at going forward with this kind of work.
Absolutely.
So I want to thank you for joining us. And with that, I've got a couple of closing announcements, but we're really grateful to have had you here with us today. And we're happy to have the paper in our special issue of Health Affairs, the February issue, special issue on housing. I encourage people to check it out. Looking ahead, the next event we have coming up is on March 19th. For the next installment of the Journal Club, as you can see there, we'll be focusing on Georgia's reinsurance waiver is associated with decreased premium affordability and enrollment, presented by David Anderson from Duke University. You can register for this event, and in fact, any health affairs events on our website at healthaffairs.org. And with that, again, I want to thank Dr. Neal for joining us, and for all of our audience members. And these are our funders for the special issue on housing and health, so we thank them as well. And with that, we are adjourned. Thank you very much.